Is there any golden advice for the young radiologists?
And the bigger hurdle was will now more and more happen in medicine and radiology also. So the new generation has to completely understand what they're going to face. You have to make that diagnosis at 1 a.m. in the night. You have to make the diagnosis at 4 a.m. in the morning.
Sir, any new machine or any futuristic gadget which is on your wish list? Namaste and welcome to Life in Focus, this podcast series where we bring you stories beyond your diagnosis, beyond your treatment, and delve into the memory lanes of your healers. And today is our very first episode. I am your host, Dr. Raunak Lakshmi Shirsath Talele, and today's guest is very special. He is Dr. Deepak Patkar, sir, my mentor and an expert in the field of radiology. Sir has carved out a niche for himself, not only as an expert in the field, but also as a true academician and an ardent teacher. Sir is the Chief Medical Director of Medical Services and Head of Imaging at Nanavati Max Super Speciality Hospital and has over 30 years of experience in the field of radiology. He has many accolades, few amongst them being the Chairman of Indian College of Radiology and also the past President of IRIA. But sir is the legendary mastermind behind the Nanavati MRI Teaching Course, which he had started for benefit of many of us. And today, we ask him about his initial story, his struggles, and the spirit beyond this mastermind. So, sir, welcome to Life in Focus.
Thank you, Raunak.
And sir, before we start this, we have recently found out that you have also been inducted as the fellow of Royal College of Physicians of Edinburgh.
Correct.
And all this many things which you have achieved. So today we want to go personal and ask a few things, sir.
Sure. Thank you for part of this initiative that Raunak has done. I am very proud of her and look forward to the episode.
So, sir, we want to know why medicine, why radiology, how were the initial days, sir?
Right. So, my नानाजी, माझ्या आईचे वडील डॉक्टर होते माझ्या गावी. ॲज अ स्टुडंट आय ऑलवेज वॉन्टेड टू डू CA. मला जवळजवळ 5वी-6वी पासून आय हॅड थॉट की आय डू कॉमर्स अँड बिकम CA. मी इनफॅक्ट पोद्दार कॉलेजमध्ये ॲडमिशन पण घेतलं होतं 11वी नंतर माझी आई आणि मावशी दे पेस्टर्ड मी सो मच दॅट आफ्टर डुईंग 10 days ऑफ कॉमर्स आय मूव टू रुपारेल and joined 11th and 12th in science. After that, during doing my medical schooling from Nair, I decided I'll become a pediatrician. पण मला pediatrician होता आलं नाही कारण मला ऍडमिशन नाही मिळालं. आमच्याकडे pediatrics was one of the first choice for people doing well in medicine, and orthopedic and general surgery was choice for people doing well in surgery. मला दोन्हीमध्ये एवढे मार्क नाही मिळाले की ज्याच्यामुळे मला सर्जिकल ब्रांच मला नको होती. But I wanted to be pediatrician or general medicine. I did not get that. That's how I got into radiology.
But sir, was like you said, radiology was not the first choice.
Correct.
But now also, do you feel that if you had an alternative choice, you would have opted for something else?
Not pediatrics. I love radiology. I am proud of what I did. पण दुसरं जे चॉईस मला मिळत आलं असतं तर आय रिअलाइज्ड ओव्हर लास्ट 20 years असो की आय कुड हॅव बीन अ गुड जनरल प्रॅक्टिशनर. आय टेक केअर ऑफ पेशंट सो मच दॅट दे गेट स्टक टू मी फॉर एव्हर. And I would have been a very good general practitioner, the art of which is now dying.
Okay. And sir, in the field of radiology also, so when you would have started, there were just X-rays.
Correct.
But now it has evolved so much, high-end machines,
Correct.
technologies,
So
AI.
in fact, when I took up radiology, the idea was, I was from a middle class or lower middle class background. Idea was do 2-3 posts in radiology because that was the only requirement we had that time to do MD, not 6 posts. आणि GP चालू करायची, थोडेसे मेक सम मनी अँड देन स्टार्ट रेडिओलॉजी प्रॅक्टिस. थिंग्स चेंज ड्रामॅटिकली. इन फॅक्ट वेन आय स्टार्टेड माय रेडिओलॉजी देवर ओनली एक्सरेज, सोनोग्राफी थोडी होती. देर वॉज बेरियम, IVPs, मायलोग्राम्स अँड लिटल बिट ऑफ इंटरव्हेन्शन रेडिओलॉजी, एओटोग्राफी एटसेट्रा. Things changed very dramatically over next 2 to 3 years. आम्ही चालू केलं त्यावेळी नुसते एक्सरे 400-500 एक्सरे व्हायचे, 30-40 बेरियम्स अँड देन अबाउट 10-15 मायलोग्राम्स एव्हरी अल्टरनेट डे आणि IVPs. reading those was a big challenge. We had Dr. Jankaria, Senior Dr. Jankaria as our teacher, and he used to teach us very, very passionately. He used to get a lot of friends from abroad. So he had done his DMRD from UK, and he used to get a lot of speakers from abroad, ex-Indians as well as foreigners, the British and Americans. And interacting with them, I realized that there's so much more to radiology than what we were doing. And that's how I decided I'll go to UK or US to learn a little bit of advances in radiology at that time. Luckily, I got a 1-year fellowship in Guy's Hospital, London, and there I realized that there's so much more to do than just X-rays and interventional procedures. And I moved into CT and MRI.
But sir, you are also a first generation doctor from your family.
Correct.
So was all this process a challenging one?
It was a big challenge. So as I said, I decided to start doing GP, but after coming back from fellowship, there were a lot of avenues that opened up automatically. I did not realize that when I went to do fellowship, things will open up so dramatically in India as well. The idea is to go learn something, come back and join somebody to do X-ray sonography practice. But I realized that if I started doing multiple things at a time, you'll be jack of everything, but not get recognized in the field of radiology. I got very, very good mentors in the form of Dr. Jankaria, Dr. Kothari, who is my true mentor. And त्यांनी मला शिकवलं की don't keep doing too many things. Focus on one thing, which will bring you the accolades that you are looking for. So I decided just do CT and MRI. Over a period of time, that time CT MRI was there, but then you had to do everything that was available on CT and MRI. There was no systematic approach to CT or MRI. There was no neuroradiology, there was no cardiac radiology, there was no breast radiology. There was everything that was related to CT and MRI. Over a period of time, I got very, very good colleagues who wanted to subspecialize, and that's how I moved into neuro and musculoskeletal radiology. पण ज्यावेळी चालू केलं त्यावेळी the thought was just go with the flow, try to do best that you can, spend more time than everybody else, focus on what you want to do, and get better and better every day.
And sir, like when I got into radiology, we have all heard that Mumbai mein the first MRI came into Nanavati.
Correct.
So for us, it was like a game changer thing.
Correct.
Now what we feel ki ata MRI ta easily milto, but it was not like that at that time.
Correct.
So were there any specific set of challenges?
So Nanavati MRI was not the first MRI in the town; it was the third MRI. Okay. I worked at a private center for 3 years, which was second MRI in the town and third MRI in the country. That's where I sort of managed everything. I used to be a single radiologist working from 8 a.m. in the morning till about 2 a.m. in the night. So about 16, 17 hours of continuous working. There was nobody who could really help me out because everybody else was doing something else. They were doing ultrasound, X-ray practice, and then come there for 2-3 hours. So end to end, we did not have good technicians because there was nobody trained in MRI technology as such. So I was the front desk person telling about how to prepare yourself for MRI, what to expect. To the technician, I used to help them planning the scan. MRI used to take about 1 hour there. And then also get right films printed, get the report typed, and then talk to the doctor. There were no mobiles, so I had to sort of wait for those doctors to come into their clinic and talk to them. So end to end, I have worked for 3 years, as I said, for 16, 17 hours, learned myself parallelly. There was no internet, so we had to look at references, getting out textbooks. So it was very, very difficult. And the bigger hurdle was the MRI center that we had in India and Mumbai. They used to think that MRI is meant for elite radiologists. Not everybody should learn or they wanted to remain on top and not get this down to masses. I had tough time getting into it. Luckily, I got fellowship in UK and I could learn MRI. But then I thought that if I faced so much of trouble, people who wanted to learn should not face that. And that's how I started this course. So people had free entry everywhere I was practicing, whether it was the first center in town or Nanavati MRI. Forget the course. Everybody who wanted to learn MR after their MD, they used to come spend 1 month, 2 months, 1 year, depending on what they wanted, and then go back to their towns and try and practice radiology and MRI.
Sir, MRI is still quite evolving.
Correct.
So radiology as a blanket term. So is it making, is it going more challenging or is it making life easier now?
I think it is going both ways. Challenging in the terms, everybody coming out after MD or DNB, at our time they could straight away start practice. There's nothing more that they could learn. Now, after coming out of MD, it is so much difficult to decide what you want to practice. You want to practice system-wise, you want to practice equipment-wise. So that's the challenge. Looking at it the other way around, you can just get into a small job and make good money to begin with. So it's getting difficult and easy both. Getting a job in radiology is very, very easy because there's severe shortage of radiologists not only across country but across the world. So it's very easy getting a job. Difficult is radiology is really evolving. So what you learn during MD is probably completely superfluous. You have to keep learning, you have to keep changing, you have to change with times, and with AI coming in, that is becoming even more difficult. So what you practice today can get completely outdated after 5 years, and you have to reinvent yourself all the time. That is true for all of us beyond radiology, whether it is doctors, whether it is engineers, whether it is software engineers. You see what is happening in software industry today or IT industry today. So that will now more and more happen in medicine and radiology also. So the new generation has to completely understand what they're going to face and keep changing with time.
So, sir, in radiology, we have these different modalities.
Correct.
So, one modality, sir, ji, tumhala vatte, or you feel like, it has been the game changer in patient care?
Correct. So, if you see, everything in radiology is game changer. Whether it was X-ray in 1896 or whether it was procedures which came in 1920s and 30s. Then a lot of game changers came in 1970s, 80s and 90s. That is ultrasound, CT scan, MRI and now PET-CT. Everything has been game changer. All these equipments completely changed the way we practice medicine, not radiology. आणि डायग्नोसिससाठी त्याने एवढा फरक केला की medicine has now become completely dependent on radiology. We are at the center of everything that the surgeon or physician or gynecologist or cardiologist operates today, or the way they treat the patient. But the real game changer is going to be artificial intelligence in radiology. I am very, very sure that it will completely change the way we practice radiology, we practice medicine. And what CT or MR did in the 80s or 90s, AI will do much more. It will allow us to work much more efficiently. So suppose I am reporting 40-50 MRIs today. I will have to report 400-500 to make same amount of money. Errors, जे चुका होता at the end of the day or when you're tired or when you're distracted, that will go away completely because somebody will keep on prompting you that you're making a mistake.
Okay.
3, it will reduce from patient's point of view. It will reduce the amount of radiation that the patient receives because of repeats, or the algorithms getting better with AI. Radiation कमी होईल, contrast कमी होईल, repeats कमी होतील. It will also triage the way we work. So when you come in the morning, you don't know what you're supposed to report, especially in a hospital setup. There will be 30-40 MRIs sitting there. There will be 50-60 CT scans sitting there. 100 X-ray asतील. When you enter the hospital, currently you depend on your technologist or your resident or your fellow to decide what is urgent, what is not so urgent. If AI can do that, I know what is to be done quickly, what can wait or what can wait even longer. ते AI करून टाकेल. शिवाय the entire workflow in the radiology, which is so chaotic today, it depends on the nurse on the other side or a resident doctor on one side versus your front desk reception on the other side. That can completely change. What to prioritize will be decided by AI. The complete workflow of scanning, treating will completely change with AI. So if I want one person who I want to get accompanied by would be AI and not a technologist or a colleague or any machine or armamentarian.
But sir, we see this trending reels or
Hmm.
something on Instagram. AI is going to replace radiologists. AI is going to take away your jobs. So is it really true,
नाही
sir?
तसं अजिबात नाही होणार. I am very sure that a smart radiologist would remain smarter than AI. And there are so many facets to radiology rather than just making a spot diagnosis that we think radiology is, or general population, or even clinicians think. ह्यांना तर फक्त बघायचंय, spot diagnosis करायचं and that's it. Radiology is much beyond spot diagnosis. It's not about passing an exam. It's not about making a diagnosis which is out of blue. Behind every image, there is a patient who can be very, very sick, who can depend completely on you to save his life. And that AI will never be able to do. The amount of information that we have about medicine, about patient's background, AI will never be able to have. So AI will help you in making accurate diagnosis. AI will help you in reducing your errors, but AI will not be able to replace you anytime. What I always tell you is bottom-up pyramid will probably go away from radiology. For example, looking at a fracture, looking at tuberculosis, looking at a nodule in mammograms, making a bone age of a sports person can go to AI. But making complex diagnosis, comparing, talking to a clinician, talking to patient, talking to relatives, we can master and get better and better. And AI will make us more accurate than replacing us.
Okay. Was there any specific moment, sir? Any story or any mentor who inspired you to take on the role of a teacher?
So there were many, there were really many, but what I can remember, and to make the conversation short, Dr. Kothari, my teacher and my mentor, was really the one who pushed me into it. When you come out of MD, for you always think of how to get busy with your reporting, how to get busy making a little bit of money so that whatever loans you've taken or whatever your parents have done for you, you want to give back to them. So that becomes priority for all of us, especially coming from middle class or lower class background. What he taught me and what I learned in UK, US, wherever I did my fellowships, is there's so much beyond reporting, so much beyond making money. Money and reporting comes automatically if you're good. To make mark in society or people around you, you have to do much more than that. And that's where I thought teaching would be the best profession. So give back to society, give back to students what you got, would earn not money, but earn you followers, earn you your fans, earn you lot beyond the money that you make. One, two, being available at all times to help your colleagues and juniors would make you a better person, a better radiologist. To getting into academics gets you recognition that your job or your reporting will not do. That's how these 2-3 people kind of made me do that. I was very, very scared of getting onto stage, talking to people. I had never done that during my student time, never done that during my residency time. So every time I went to present something or every time I went to give a lecture, I should think why I'm doing this. It is not mandatory. To at times it is waste of time, because beyond your working hours, you have to do that extra bit, prepare yourself. At times it can be quite painful because you have to do it at a specific time. Now things have become easy with internet around, with references around. Things have become so much simpler. At that time, to make those slides, you have to take a photograph, make a carousel-like slide, go to Kodak company, get those printed. It was so much difficult. And to do that beyond your working time was even more painful. The photographer will not be ready with the pictures that you want. You have to repeat them. You have timelines to follow. And then once you make those slides, your seniors or juniors will flick them. And next time when you give that same lecture, you have to do it again. So it was a very, very painful process. But I'm so proud that I did that. And that gave me recognition beyond what I would have even dreamt about 30 years back.
It's a Nanavati MRI Teaching Course. For my generation, it's a mecca of radiology. Once in your radiology, you have to do it in your training.
Correct.
But how was it started, sir? The whole idea beyond the process.
So when we started it, the idea was just to have a small group of people who would come share their lectures and cases. We started on a very, very small scale. So first one, we started way back in 1998 and it was very informal. We used to call it as confluence. So 10, 15 radiologists who knew MR would come together, share the cases, and then maybe 30, 40 residents or fellows would attend that. So first conference I remember in 1998 was attended about 40, 50 people. And the traction that we got was more encouraging. So we thought, let's do it in a formal way. So 98, 99, 2000, we do it informally in our own auditorium. 2001 is when we shifted to Tata Hospital because Tata had a bigger auditorium. The capacity was about 250. Our capacity was about 100, 125. And the way the response started coming, we thought we'll move to a bigger place. In early 2000, 2010, we used to get about 400, 450 people. COVID time, we went online, and for 2-3 consecutive years, we got 1,500, 2,000 people. What is more fulfilling is everywhere I go for CMEs or everywhere I go for lectures, everywhere I go in the country, outside the country, there would be at least 2-3 people coming to me and telling me, हम लोग जब स्टूडेंट थे तभी वो आपका नानावटी कॉन्फ्रेंस अटेंड किया था, and we learned a lot from that. And these are people who are now working in Mayo Clinic, Sloan Kettering, Singapore, Australia, wherever I've traveled and interacted. In India, it has just become like Raunak said, it has become a Mecca. There are people who have attended this 10 times, 12 times, proudly so. And in fact, I feel bad कि वो 10-12 बार आके क्या सीखेंगे, because it is many times, a lot of it is repeat, 80% of it is repeat. We celebrate our 25th MRI teaching course in 2026. Yes. And I'm looking forward to meeting those people who have attended it for years together.
Yeah, I think there are few people who have attended it in even more than 15 times and also.
Correct. And not knowing MRI.
Some people actually say that we go to the course, we get those CDs, we revise, and that's how we start reporting an MSK scan or something. Like they may have reported brain angio, but MSK and all, it really is a game changer. So, sir, as a teacher, is there something you constantly hope that the students should learn other than radiology from you?
Yeah, in fact, now I tell my people, I have 10, 12 colleagues, we work together, about 13 of us work together. So I tell them, don't learn radiology from me, because there are better people who will spend time with you. I have little time to spend because I have administrative work, I have a lot of other things to do, a lot of meetings to attend. So although I spend about 8-9 hours in my department and 2-3 hours outside the department, there's very little time that I'm left with to formally teach. Previously, when there used to be 1 or 2 fellows sitting next to me or 1 or 2 residents sitting next to me, I used to actually teach them anatomy, start reporting. I would dictate. Now we have, of course, voice recognition softwares, but they used to write the report, they used to get it typed, they used to get it corrected and signed. So that was a very, very formal way of teaching people. And I did that for almost 20-25 years. After I became medical director, that was getting more challenging, and we now have colleagues who are better than me in teaching. But what I tell people around me is learn beyond radiology, and that is being patient-centric. Keep patient at the center of whatever you do throughout your life, not only during doing reporting. 1, 2, be available, because we as radiologists, when we take radiology, are taught that it's a kind of 9-to-5 job. And as we come out, we realize it can never be a 9-to-5 job. Finally, you are a doctor who's changing patients' life. Finally, you are somebody who's going to make diagnosis upon which everybody else is going to depend completely on. You cannot report 9-to-5. You have to make that diagnosis at 1 a.m. in the night. You have to make the diagnosis at 4 a.m. in the morning, and it has to be correct, because after that the treatment is going to start. So if you made any error, patient's life can change, and we have to understand that we change lives. Unless we understand that, whether it is ultrasound, whether it is X-ray, whether it is CT or MR or PET CT, we constantly change lives, we constantly change treatments, we constantly change everything that the patient is going to undergo. And unless we become responsible clinicians, we can never be a successful radiologist.
But sir, the like you can say the new crop or the new generation which is coming up, they are a little bit more impatient, I think.
Correct.
So when they say ki I took radiology because I want those high paying institutional jobs,
Correct.
or why to start a center, why to learn the business aspect of it, or you know why to buy those high end machines. So is there a mental list, like you know a checklist or pointers on how they should decide, like why, what, and what they should do so that you know even they can establish themselves?
Correct. So first of all, they have to understand that they have to love the subject. And when you pass MD, you have maybe 4, 5, 6 decades of what you're going to practice.
Yeah.
I would say take your time. For our generation, we had to immediately start our job. Now, most of the students who come, there is completely different way they learn. So I jokingly say, and I don't want to be very critical about it, that हम लोग जब भी एमडी किए तभी हम लोग को सीखना भी था, not only radiology but practice करना सीखना भी था. So we used to learn and start practice immediately. The students now come with a clear thought that 3 साल खाली पढ़ना है, सीखना नहीं है. 3 साल पढ़ना है, पास होना है. So their 3 years are invested in reading and passing, not in learning radiology. And I have now fellows who pay 8 lakhs a year to learn radiology. So there's a complete shift of the way we learn and study. We split study and learning. I don't really propagate that, but that's how it is. So we have to change with time. So people spend 1 year, 2 years, 3 years doing paid job, unpaid job, or paying job. 3 ways to learn radiology. So I would say a lot of people will think it is waste of those time, but I would strongly propose that they should spend 1, 2, 3 years, depending on what they can afford, in deciding what they want to do. Now we have lots of options. You can just join a high-paying job, like Raunak said. You can start your own setup. You can become a professor, which is not a bad idea. Professors now paid well. You can get into interventional radiology. You can get into subspecialization. You can get into AI. There are lots of options. The option that you are going to choose has to be one which you think you're going to enjoy for next 30, 40, 50 years. And it can be very difficult to decide that immediately after MD. So I would say, take your time, spend good time with mentors, decide whether you want to be a professor, you're going to be a private practitioner, or you're going to be a part of chain of diagnostic centers or chain of hospitals. So माझ्या दृष्टीने थोडासा टाइम घ्यायला पाहिजे पास झाल्यानंतर, MD, DNB पास झाल्यानंतर. Spend good time with good mentors, try to subspecialize, decide what your personality is about. You want to take risk, there is a lot of opportunity in starting your own private practice. If you don't want to take a risk, spend some time in diagnostic centers or hospitals, see whether that suits you or no, or go back to pure academics. Other options are interventional radiology, doing AI. A lot of companies, startups will come up where you will get a good job, which is not patient-centric, which is not front-facing. So if you're an introvert, you have a lot of options. If you are extrovert, you have even better options. And next 10, 15, 20 years, radiology is really going to boom. So you are in the right place at right time. The choice as to what you want to do will be completely yours. Also, I would say, don't go in one direction. If you have decided something which over 2, 3, 4 years you realize that this is not my cup of tea, don't be scared to take those decisions and deviate, start doing something afresh till you start enjoying it. Because as I repeatedly saying, 30, 40, 50 years, what you're going to practice cannot be decided in 1 year or few months. Take your time, take the right choices. If the right choices turn out to be wrong, change your choices.
It's a very few radiologists of maybe my generation or maybe who are younger. They are very scared to start own setup because obviously of the high cost of a radiology setup. Also, they keep on saying that you have to learn the business aspect of it. So,
Right.
is it really different or it goes hand in hand?
So it actually depends on where you're going to practice. If you go to B town, C town, where there is dearth of radiologists, you can really do well financially. I don't know whether a lot of people will opt for it because it's a balancing that you have to do. If you go to those B, C towns, you're worried about your own children, what kind of education they will get.
Okay.
Two, if you fall sick, whether you'll get right health support because there are no good hospitals there. You're worried about your parents falling sick. So it's a difficult decision. But there, you really don't have to know the nuances of business of radiology. If you are in a town or metros, it is fiercely competitive. So
Yes.
then you have to really learn nuances of business of radiology. And for that, then I would say spend good 3, 4, 5 years with people who are already doing it. See whether you can do what he is doing. Because when you are doing your private practice in a metro or in a town, you are not only a radiologist who knows subject of radiology, you have to be somebody who understands business, understands marketing. So you are not only radiologist, you are CEO, CFO, chief marketing officer, chief IT officer for your department, for your center, for your processes that you're going through. And it's not very easy and it's not everybody's cup of tea because we are trained in a very different manner compared to what the people who are doing business are trained. The MBAs or people who go to London Business School, people who go to Ivy Leagues in USA, they are taught the business of medicine, business of anything in a very different manner. For us, it's learning as we go along, and it's not going to be easy anymore in metros. So it's a hard yard that you have to run through, and it's much beyond radiology, and it's not easy. But if you master that, the joy that you get is going to be much more in terms of achievement compared to what you would do in a run of a mill kind of a setup.
Okay. And then it comes to the public aspect of it, sir. Radiologists are not get, they don't get that much of recognition from general
Correct,
public.
correct.
For them, we are just people who see photos, या
True,
सिर्फ images
true,
देखते
true,
हैं.
true.
So how to deal with that, sir?
So I would completely blame radiologists for it. They prefer to remain behind the film. We have to make a very concentrated effort to change our image, and it's not going to be easy because naturally the patient goes to a physician or a surgeon or a gynecologist or a rheumatologist or a neurologist for their problem. They don't understand the difference that we make in their lives, the difference that we make in the diagnosis, etc. So for me, the advice is very simple. You have to be front facing everywhere you go, and I do that very, very vigorously. And as I said, it's not easy, it's very difficult. But being part of the treatment that the patient undergoes is very important. It's not about, oh, photo dekh liya, diagnosis kiya, and then forget about it. You have to call back the patient, you have to call back the doctor to check what has happened. Get involved in the whole process of healing. And unless you do that, you will never get recognition. The other way of getting recognition is remain on the top of your business. So whatever you're doing, whether you're doing fetal medicine, whether you're doing breast imaging, whether you're doing neuroradiology, whether you're doing MSK radiology, whether you're doing interventional radiology, you have to be cut above everybody else. That's the easiest way of getting recognized. People then flock at you because they know that you'll give them that 10% more than what everybody else will do. So there are these two ways of getting recognition.
Okay. And sir, we know you must have done millions of cases till now.
Correct.
Anything specific which comes to your mind which was very special, any diagnosis or outcome which actually changed your outlook also?
So there are many like this, and you must have heard me saying, you made my day, you made my day.
Yes.
So when I report 30, 40, 50 scans, sometimes 100 plus scans, there are 2-3 cases where you require to use your hippocampal frontal lobes, and that's what gives me a kick. So there are many like that. 2-3 which I can remember is what made the difference in patient's life. There's a one very big time patient of mine, 30 years back. He did his MRI somewhere else, and it came to me from his referring doctor, his treating doctor, for second opinion. This was diagnosed as a lymphoma because there are a lot of lymph nodes in the retroperitoneum inguinal region, and there was a lesion in L4 vertebra. It was called as lymphoma or some kind of malignancy. His films and CDs were sent abroad to prepare him for chemotherapy and radiation. And I thought it was not so, it was TB. And TB at that time was thought to be disease of a poorer community, not elite people. We biopsied that and it turned out to be TB. And that made or completely changed his life. And there was another patient who made me give sleepless nights. A sole bread earner for a family of 8, had a benign tumor which I diagnosed in the frontal lobe on MRI. Unfortunately, that was diagnosed as a malignant tumor on CT scan. So I thought I made a big difference to his life. Unfortunately, although it was a no-touch kind of a tumor in frontal lobe, the neurosurgeon thought otherwise and he operated it. The tumor ruptured and patient died of chemical meningitis. So that made me think that whatever best you do for patient may not always be best for the patient. Unfortunately, we have very little control over this. This actually gave me sleepless nights. I could not sleep for 5 nights thinking what would happen to the children, mother and wife of this patient.
And sir, we actually, are involved in the process, but clinicians don't think so. They usually think कि you use words like आप ऐसे words use करते हो, suggestive of or suggest this or likely. You guys keep an ambiguity. So is there a way to avoid this, sir?
So unfortunately, patients and the clinicians don't understand the limitation of imaging. There are so many things which look similar. There are so many things which can completely flip the diagnosis. Same looking things can be two different things. Two different looking things can be same things. Unfortunately, that's the limitation of imaging. People don't understand that. Many of the radiologists also don't understand that. They want histopathological diagnosis. I think that is completely wrong. But to put it across to the other community can be extremely challenging. So what I do is I pick up a phone, try to get more history, try to interact with the clinician and the patient or the relative, and try to get as specific as possible. Having said that, that's not always possible. You don't have to sit on the fence, but you have to make the patient and the clinician understand that, see, 90% of the times I'm giving right diagnosis, 10% of the times it is not going to be possible. So one way of convincing is tell them that this is what I think, but I can't put it on the paper. I am going to put differential diagnosis. They of course have to be minimalistic. You can't give 10 differential diagnoses like exams. It can be 1 or 2 more than what you think it is. Fortunately, over last 10, 12 years, American College of Radiology, European Congress of Radiology have started a system which talks about the percentage chances of what you've made. So whether it is BIRADS, ORADS, LIRADS, all these things are making our lives easier. So convincing clinicians to understand what your diagnosis is fitting into category 1, 2, 3, 4 is the way forward according to me.
And sir, like so many years, like you say, even a little diagnosis gives you sleepless nights. So going through all this process and achieving so much, was there a family time which you had to cut upon? How to maintain the work-life balance? Sir?
So this is the most difficult question you asked me, and I won't like to answer that question. Having said that, look at Olympians. Look at, for example, politicians. We think that they're bad. Olympians, we think they spend 4 years, 8 years getting into that gold medal, and out of thousands or millions of people, one person is going to be successful. Out of politicians that we see around, there will be good ones, bad ones. So I think all of us represent a society which we are part of. There will be 10% good, 80% average, and 10% bad. So we should not look at only the bad ones. Good politicians who actually want to do good for the country and society spend 18, 19 hours every day for years together. And to be successful in any format, cricketers spend 6 hours of training. They don't play cricket for 6 hours, they play fitness for 6 hours. Anyone who wants to be successful has to do those hard yards. And if you want to be better than everybody else around you, you have to put those hard yards. So when I spend 12 hours into my office, there are another 6 hours which go beyond office, where you have to do something more than what everybody else is doing. And unless your family, your spouse, your children are with you, it is not going to be possible. Again, if I really want to compartmentalize what a new generation radiologist should do, if you want to be above board, above everybody else, first 10-15 years are going to be very, very challenging. You have to put more effort than everybody else around you if you want to be a successful radiologist. And unless your spouse and children understand that, you cannot be successful. So it's a balancing that you have to do. A lot of people talk about a work-life balance. I don't believe in that. And I don't hate people who believe in that. But if you want to be better than everybody else, your work has to be work-work balance and not work-life balance. And I strongly believe in that. Work harder, work better than everybody else, and work smarter.
Sir, we understand that you are an analytical mind, but were there any instances where you felt that there was some other divine energy or something which, it influenced the outcome?
That's completely true. And I learn that every day, every morning, every afternoon, every evening. I don't believe in God because that's how I was brought up. My father, mother did not believe in God. My wife strongly believes in God. So I do a little bit of balancing. And I believe God is there. And God has made me what I am today. Of course, my efforts are more important than everything else. But being at right place at right time is very important for all of us. I got right colleagues, I got right mentors, I got right juniors, I got right patients, which made me what I am. Divine intervention is very, very important. So I see patient's outcome. What you kind of brush off कि ये गया अभी कुछ फायदा नहीं करके, they come back to you years after years, getting treated very well. And then there are people who think will come back completely healed after 2 days of surgery, come back home and come for follow-up with nothing remaining, come back with worst possible complications, spending months in ICUs because something has gone wrong. So I think it's all luck. It's not about surgeon, because surgeon would never get into OT saying that I want to do bad to this patient or good to this patient. Radiologist would never get onto your packs thinking that I want to make a wrong diagnosis or right diagnosis. It's just the circumstances of things going wrong. We talk about contrast. We don't even take a right consent when we give contrast to the patient. We know that 1 or 2 in a million will actually die of receiving contrast, but we don't think about them. So being lucky and having divine support is very, very important according to me. And we take it for granted, unfortunately.
So, sir, just to sum it all, is there any golden advice for the young radiologists?
So there cannot be a golden advice. There are thousands of advices which I can give, and I do that whole day, morning, afternoon, evening. People get sick of me. Simple advice is work hard, work smartly, do what you think is right. There'll be noises around you. You have to cut the noises. Enjoy what you do, and if you don't enjoy, change the profession. There are a lot of options today. You can do that all the time. And as I said, AI will actually force you to change your profession every 5 years. And unless you're smart enough, you cannot enjoy what you're doing. Keep doing hard work all the time and work smartly.
Sir, any new machine or any futuristic gadget which is on your wish list?
So gadget on my wish list for last almost 25-30 years is MR, which will happen in a matter of few seconds or milliseconds, like a camera, and it being noiseless. I know that is not so easy and may not happen in my lifetime. So the biggest gadget I'm looking forward to is AI tool. Somebody hovering around me, making my efficiency better, giving me more time to have that work-life balance that the new generation looks after. Looking forward to. But I would probably spend more time with AI to give more productivity than having my work-life balance and working smartly with AI.
So coffee, tea or ice cream, your favorite for long sessions?
Uh, so coffee, tea, and ice cream, none of them is my favorite. My favorite is an intelligent colleague sitting next to me, correcting me, having some intelligent discussion. And by birth, I think I'm a little hyperactive. I can't sit at one place for more than 40-45 minutes. In our library, my co-registrar used to sit from 8 a.m. to 10 p.m., 14 hours with only bathroom breaks. I used to have apparent tea breaks, which are not actually tea break. There will be batata vada break or medu vada break every 45 minutes. I do that even now. I can't sit on console for more than 40-45 minutes. So finish 10-15 reports, move out, trouble people, come back and have an intelligent radiologist sitting next to me. ये क्या लग रहा है? ये ऐसे क्यों नहीं? ये वैसे क्यों नहीं? That's what I enjoy.
And sir, one single report which you have still not forgotten.
So I remember another celebrity who had wasted almost 4-5 months of her time in diagnosing something. So she kept doing ultrasounds, kept doing CT, and when she came to me, she had sarcoma of endometrium, which is an extremely rare condition and very, very aggressive condition. So by the time she came to me, a lot of time was wasted. The disease had gone to liver, peritoneum, everywhere, lymph nodes, and I thought it's done and dusted. The life expectancy would be 6-8 months. That's how we discussed it. But she had a killing spirit and drive to live for her child. Went to Sloan Kettering, got operated with robotics at least 7-8 times, received chemotherapy, received radiation, received Tibetan medicine, got well completely. She comes to me for the last 10 years and completely disease free. So something that you think is not possible happens if there is willingness from doctors and patients both. That's like a big learning lesson for me of my life.
So in one word, if you have to describe the way you work, what it will be? A detective, a seer or a healer?
None of them, probably a healer, because I try to make best for the patient and anytime 24/7. But we are neither of them. It's God who actually decides what it is. Our job is to work smart, work fast, and make least errors. So I want to be workaholic, making right diagnosis all the time. Healing happens parallelly, and I'm proud to be that.
So, sir, thank you first of all for joining us today. A very, very big thank you for us and from the entire team.
Thank you.
And also, sir, thank you for generously, sharing with us all the ideas, different opportunities, goals and paths. And thank you for being so warmful and also giving these small nuggets which will really help us be better radiologist, or I'll say better human as in whole. So thank you for joining us, sir.
It's completely my pleasure, and I look forward to many more like this from many more people who are kind of more experienced than me, have more to tell about life, and looking forward to this.
And to our listeners, if you really feel that there is something more you want to know about radiology, please drop a comment and we'll get back to you. And also about something you want to know in more depths about. So until next time, when I get a naya guest, a nayi kahani, stay focused and stay human.